High-dose interleukin-2 has been approved by FDA and has been used for last almost 25 years. When the VEGF TKIs came for kidney cancer treatment and other targeted therapies came up, the enthusiasm for high-dose interleukin-2 actually went down. And we have seen a resurgence in immunotherapy in general with PD-1 inhibitors, checkpoint inhibitors coming up. And I think that has led to, or should lead to, increased enthusiasm for our oldest immunotherapy, which is high-dose interleukin-2 therapy. In the talk I gave today, we presented the data from two large NCI-designated comprehensive cancer centers, including ours, which is Huntsman Cancer Institute at the University of Utah and University of Michigan. We had almost 400 patients, and we showed that we did see the usual 16 to 20% objective response rates, which had great survival benefit with high-dose interleukin-2. But then additional 30% patients who had stable disease, they did not necessarily had response, but they had stable disease as the best response. They also had survival benefit, which was very similar to those patients who had partial responses. To summarize this, almost 50% patients receiving high-dose interleukin-2 in these two centers had survival benefit, which was almost as good as what we saw with PD-1 inhibitor as far as responses are concerned, or stable diseases rates are concerned, very similar to nivolumab in the phase 3 trial recently reported by Dr. Moser. So what is my take on IL-2? I think high-dose interleukin-2 has resulted in very meaningful survival benefits over the last 2 decades. And it should continue to be offered to the patients who have good performance status and who are candidates for high-dose interleukin-2. I think the future challenges are how to combine high-dose interleukin-2 with the newer drugs like PD inhibitors or checkpoint inhibitors to make it even more effective and more efficacious treatment for our patients.